Hi everyone, and welcome to tonight's webinar on behavioural and psychological symptoms associated with dementia and dealing with challenging behaviours. Thank you for taking the time to come to this webinar. My name is Hoda Sanai from the Sydney North Health Network and the Northern Sydney Local Health District. I'd like to first start with acknowledging the traditional custodians of the land on which we meet and work. We pay our respects and recognise their continued connection to land, water, and community, and honour their ancestors, elders, past, present, and emerging. A few things before we continue. If you're not familiar with changing your display name, we ask that you kindly please switch on your, change your participant name to your name and ensure that your microphone and video is disabled. However, the webinar setting should do this for you. The other thing is to please interact with each other and submit any questions that you have into the chat box. And if you have any issues, you can please also say having issues in the chat box and we can try and see if we can assist. The other thing to note is just to please be respectful of other participants, just like you would if we were face to face. If your screen freezes, you may have an internet issue or Wi-Fi connection is limited. So please just try and move closer to your Wi-Fi router. And the last point is we will end the webinar tonight with an evaluation. And we just wanted to get some feedback as to how you think this webinar went and any other feedback that you have. We'd like to start with talking about some of the services that the Primary Health Network commissions and supports with. So COVID Home Service. The Sydney North Health Network is in collaboration with the WISE Clinic, which is a specialist emergency clinic, and they have set up a mobile medical service to support face-to-face clinical assessments for people in isolation due to COVID. So these are some of the details in regards to how to refer and numbers and any other information that you need. But also please feel free to reach out to us if you would like any additional information. Health Pathways is something else that we are working with the Northern Sydney Local Health District on. Health Pathways is an online health information website which supports GPs, hospital doctors, nurses, pharmacists, other clinicians in accessing information relating to particular issues or clinical issues regarding your patients. It has a whole list of services that you can access, and you can search by issue, you can search by a particular age group. So for example, we have a dementia section in Health Pathways, and we do have a specific section named Behaviours and Psychological Symptoms of Dementia, BPSD. There's a whole bunch of useful information there. There's also some information in regards to how to access Health Pathways. You do need to sign up, and there are some helpful links here on this webinar that you can understand how to kind of get access to Health Pathways. We also have a video to help you become more familiar with Health Pathways as well. So yes, we do please encourage you to use this at the point of delivering patient care as well. We have also listed a series of other support services suitable for patients that are older, frail, with dementia, that are local to our region. And I know it's a very small text, so we will be sending this out to all the participants on this webinar. And all of these services are tailored for assisting patients that are older and frail, and the referral pathways, numbers, and other information has all just been compiled into these slides. So we hope that this is useful for you. The green shows non-urgent services that would be suitable to refer patients to or for general information for clinicians. And this next slide are for urgent services that may come of assistance when dealing with patients of this age group, and how to get access and what are the types of appropriate referrals, and how to access those services. I'll now hand over to Hema to talk about the Dementia Quality Improvement Program.
Hi, everybody. Thank you, Hoda, for that. I just wanted to mention the Dementia Quality Improvement Program. This program's been running since 2018 and really encourages general practice to have a deep dive into all things dementia. The purpose of it is really to assist and support practices to look at what they're currently doing in the management of dementia with their patients, and then look at supporting them with resources and information, education to really change that and improve that management. We've got an extensive quality improvement guide, and we've looked at things like building a dementia register, early identification of people at risk, recall systems, which memory tests to include in the health assessments, looking at medication reviews, and a whole bunch more. The education workshops that are associated with the program run 3 or 4 times a year. Now, they're very small group format, and we found that the peer discussions and the discussions with specialists such as Sue, who's been with us through the program, are really lively and cover the day-to-day issues that health professionals are facing. So some of the examples are looking at things like fitness to drive assessments, discussing the role of the GP and the Geri, when to refer, how to manage those patients, some of the comorbidities to look out for. And another key outcome of the education workshops was looking at services and referral pathways. And we identified that there was a need to assist health professionals with navigation of these services. There's a lot out there, but it's not always easy to know which patient to refer to where. We're also looking to discuss dementia-friendly communities in the future, and looking at dementia-friendly practices as well. And also medication management will come up. Next slide. Oh, can I have the next slide, Hoda? Thanks. To support the practices and everyone, we've created or improved the dementia program page on the Sydney North website. So we've got health pathways already, but just sometimes you don't want to go through that system. So a very quick bundle of resources in here. So there are quite a few clinical resources specifically around dementia, some academic articles as well. The referrals section really reflects what Hoda has also already talked about. So you can do a quick link into there and look at Dementia Support Australia, DBMAS, the Home Nursing Service, and also things like Dementia Australia's suite of programs as well. And I can provide a link in the follow-up email after this. And lastly, Sydney North's really looking at building dementia-friendly communities within our whole region. And there are quite a few different initiatives in the region to support this. These initiatives and activities are guided by the experiences of people living with dementia and their carers. And they can range from things like dementia cafes, exercise classes, information sessions, and also carer support. And also encouraging businesses to become more dementia aware. So if you would like to get some more information about the Dementia Quality Improvement Programme, please send a reply email to Robbie when you get the emails after this session, or you can go onto our website and our email address is there. You can contact me. Thank you very much.
Thanks, Hammer. So for tonight's webinar, we do have some learning outcomes. These are some of them, and if you do want to explore or discuss anything further, please do reach out to us and provide your input, and there will be the evaluation at the end, which you can do this through. Tonight we have two speakers, Professor Sue Kurrle and Marie Alford. Professor Sue Kurrle is with the Faculty of Medicine and Health at the University of Sydney and Director at the Cognitive Decline Partnership Centre. She is also a geriatrician and clinical director at the Division of Rehabilitation and Aged Care at Hornsby Ku-ring-gai Hospital and Community Services. Marie Alford, the Dementia Centre. Marie is the head of Dementia Centre Services, HammondCare, and the Dementia Centre. In this role, Marie leads the delivery and operations of programs including Dementia Support Australia. She is responsible for projects across the Dementia Centre with a focus on improving the quality of life for people in need. So we welcome them both and thank them for their time. We will start with Professor Sue Kurrle, and then we will move on to Marie. So I'll hand over now. Thank you.
Thanks, Hoda. I'm going to share my screen and hopefully this will come up and the system will work. Okay, so yeah, we're here tonight to look at behaviours and psychological symptoms of dementia. And it's particularly lovely that I can do it with Marie because we've been working together for an awful long time, looking particularly at this area of dementia. But I was asked to start by actually just saying a little bit about dementia, sort of early dementia. And I thought, I think that is important, just around the diagnosis of dementia, as Hoda mentioned. And I just want to remind you, there's a sort of gradation when we're looking at dementia. And normal aging, in normal aging, there is a gradual decline in working memory, but we maintain our vocabulary, our general knowledge, and our occupational expertise. That we don't lose that, we just get a little bit slower. We don't multitask as well. And the really big thing that people often ask me about is the decline in the ability to remember names. And I noticed that. I've noticed it for years, and I notice it in a lot of my colleagues. And it's actually measured to start at about the age of 40 or 45. So don't be worried. You need to remember the person, but it might take you a little while to remember their name. That's not dementia. Then we have mild cognitive impairment, which used to be called, and I love the name, benign senescent forgetfulness. And it's where you've got subjective complaints of memory. So you feel your memory's not terrific, and you do have some deficits on objective examination. So, when we check your short-term memory, you mightn't remember all 3 words that we ask you to remember after several minutes, or all 5 words if we're looking at the Montreal Cognitive Assessment. But, and maybe you don't do so well in demanding employment or social situations, but generally you're still coping well, and there's no significant changes in day-to-day function. And that's really important. And I remember one lady who was sacked by her bridge partner because she forgot calls. And I kept seeing her for 18 years and she never got any worse. She had mild cognitive impairment. She had problems with her memory, not huge. She still continued to live at home and do everything fairly independently. And then we get to dementia, which is the progressive irreversible syndrome of impaired memory, intellectual function, personality, and behaviour. And the really important thing is that it causes significant impairment in function. You can't have a diagnosis of dementia if you haven't got that significant impairment in day-to-day function. And I think it's really important to remember that and know that, and perhaps reassure patients about that in the future. Just to remind you, dementia is common. Maybe getting close to 500,000 people with dementia in Australia, maybe close to certainly 900,000 by 2050. Now, I won't be around to worry about it then, but it is certainly a significant increase. The important thing is it does increase with age. At 65, 1 in 12 people have dementia. At 80, it's 1 in 4. At 90, it's 1 in 2. It's the leading cause of death for women in Australia now, and second highest for men, and I think it'll catch up soon. And we mustn't forget the approximately 26,000 people under the age of 65 with dementia, some of them with genetic issues, and my youngest patient was 31 and 6 months pregnant when she came to us. So you will see it then, but it's pretty unusual. But the 45, 50, 55, 60 is not nearly as uncommon as we would like to think. So it's important to remember that it does occur. I heard tonight on the sports news as I was driving home, I think that the former captain of the Welsh rugby team has been diagnosed with younger onset dementia at the age of 41. Now, he's got chronic traumatic encephalopathy, too many hits to the head, and we are seeing that coming up more and more often. But if you look in Australia generally, the main cause of dementia in Australia is Alzheimer's disease. 70%, around that, 2/3 to 3/4 will have Alzheimer's disease, but often they'll have vascular dementia as well, perhaps, particularly if they're a little older. And so mixed dementia, the mix of Alzheimer's and vascular dementia is common. Don't forget dementia with Lewy bodies. If you have Lewy bodies, which are tiny pink inclusion bodies in the cells, if you have them in the back of your brain, in your brainstem, you get Parkinson's disease. If you have them in the front of your brain, you get dementia with Lewy bodies. And the big thing is those vivid visual hallucinations and their incredible sensitivity to antipsychotic medication. And then frontotemporal lobar degeneration. We see the frontal version is where people make really crazy decisions or unusual decisions. The temporal version is where people have speech problems. But it's now called frontotemporal lobar degeneration because they don't often get dementia as such, as we defined it in the previous slide, for quite a while. Now, how do we diagnose dementia? And I rarely make the diagnosis in 1 or even 2 visits. I'll often see someone 3 times, unless it's really, really obvious, because you don't want to label people and it can be something else. And I love it when I can undiagnose people. But I think the big thing I think is important is using a good screening test. And the diagnosis is made on the history, on the examination, which is what we might do here, and on the information from family members. So you've got a tripartite way of making the diagnosis, if you like. And certainly don't forget our memory clinics certainly at Hornsby. It's a very active memory clinic, and also at the other hospitals. The geriatric clinics will often do it. I've put up here the test that I like to use, the Montreal Cognitive Assessment, because it tests a whole lot of different areas. That very first one, top left-hand corner, Trails B, is really great to see if someone can drive. If they have trouble with this, doing numbers and letters alternately, if they have real problems with that or with visual spatial issues, you've got to think twice about their driving. So that's useful. There's a whole lot of things. There's language, there's abstract thought, there's repetition, and you've got to remember 5 words. So commit to memory, face velvet, church daisy red. I mean, there's lots of different versions of this, but I think I say them back to myself often. I might do this test in some cases several times a day. And it is interesting if people can't remember the words when you say, now, what were those 5 words? And then you say, the first one was part of the body. Oh, face, they say straight away. Fabric, velvet. So in other words, it's gone in, but they have trouble getting it out. You give them some cues and they can get it out. It's not so much an Alzheimer's picture as maybe mixed dementia or vascular dementia or dementia with Lewy bodies. It's just useful. It's just part of the scoring, but I find it very useful to do. It's the one that Donald Trump is alleged to have got 30 out of 30 on, but when the Surgeon General held up the form, it was actually blank. They hadn't actually scored it. So I often wonder about that, but I mention that as something that's important. And finally, I think it's really important for all of us, young and old, to remember the large number of risk factors that if you reduce them, you reduce the risk of dementia. This was from the Lancet Commission on Dementia in 2020. It's probably the final word on risk factors. And you can see the importance of less education, of the issues around physical inactivity, smoking. What's interesting is air pollution, hearing loss, traumatic brain injury are all in there. Ones we didn't necessarily know as risk factors. So I put this up, and the whole presentation will be available after this webinar. I think it's really important that we think of this all the time when we're seeing our patients, young and old, because it's never too late to take up the exercise, the mental activity, stop the smoking, watch the blood pressure, maybe use the hearing aids to reduce the risk of dementia happening. Okay, so that was hopefully, Hoda, that covered the dementia, diagnosing dementia part of it. Now I'd like to go on to behaviours and psychological symptoms of dementia, which is an area that has been close to my heart for many, many years. And I should note that my mum had dementia. She died just before Christmas. But we went through a number of these, and I learnt an awful lot from her and from a lot of my other patients, and you'll hear some patient stories. So why is it topical? And these pictures always give me goosebumps. These were pictures that were presented to the Royal Commission into Aged Care Quality and Safety. And they're a picture of a guy called Terry Reeves before and after he had respite care in an aged care facility in 2019, when his wife had to go back to Europe to bury her father. And I think it just shows he was given antipsychotics to calm him down. He didn't have a psychosis, but he was walking around the facility asking where his wife was. And they filled him full of antipsychotics. I think a picture is worth 1,000 words. We know that the Royal Commission to Aged Care Quality and Safety brought up a number of recommendations. This is just some of them around looking after people with dementia, the post-diagnostic pathway. Marie will talk about specialist dementia care units and the whole issue of regulation of the use of physical, chemical restraints. And I will certainly touch on that. But I want to remind you, we are talking about an illness tonight in terms of dementia and the treatment for an illness. And it is very unusual that you could call that chemical restraint. And I do want to make that really clear. But if you do, you need a restrictive practice as substitute decision maker. And that's yet another complication. So what are we talking about when we talk about behaviours and psychological symptoms of dementia? And look, there's a lot of discussion about whether this is the right word. Should we use change behaviours, challenging behaviours, responsive behaviours? There's all sorts of words. I still call them behaviours and psychological symptoms of dementia because that's what they are. And they're symptoms of disturbed perception, of thought content, of mood, of behaviour, and they frequently occur in patients with dementia. That's the general definition. We know that pretty close to 95% of people with dementia will experience some of those symptoms during their dementia, the progress, and some of them get it before they even get the cognitive changes. You see the anxiety and the depression. We know that about 80% of them last around 18 months, but they do eventually pass off. I feel very strongly that BPSD, they're an integral part of dementia, even though we concentrate much more on the cognitive symptoms and the memory loss and the intellectual changes. These behavioural changes are really significant, and Marie will talk a little more about that. We know you can get the symptoms from well before you get the cognitive symptoms of memory loss. Remember, of course, with Alzheimer's disease, the changes are there in the brain up to 20 years before you get the cognitive symptoms. And certainly you see the anxiety, the depression, pre the cognitive symptoms. And we know that if you've got BPSD, you're going to go downhill a bit faster, both cognitively and functionally, and probably end up in care sooner. And I think it's very important not to be nihilistic about them. They are usually manageable and can respond well to a combination of therapies. So what are we talking about when we actually talk about the behaviours? So aggression, wandering, restlessness, agitation, sexually disinhibited behaviour. You can read them. Screaming or cursing, hoarding, anxiety, depression, hallucinations, delusions, apathy, withdrawal, irritability. So a real, it's quite a wide variety. And then the ones, and look, I hope when I get my dementia, I get the elation. But I haven't seen it often, but elation, confabulation, so making up things. And I've heard some of the best stories. My mum was very good at that. Perseveration, going over and over the same thing again. Misidentification, where you think someone is someone else. Sometimes that can be hallucinations. Sundowning, which we all know if we've had toddlers. Arsenic out, that late afternoon, early evening when it's really hard, and when someone's tired and irritable. And you see the irritable behaviours in people with dementia. You can see eating disorders, either overeating or refusing food. The shadowing and stalking is something that is really, really hard to manage, and is what people often worry about. The fact they have to take their husband to the hairdressers with them because he can't be left on his own. The wife that stands outside the toilet while the husband's having his quiet sit. That shadowing behaviour is really an issue. And then resistiveness to care, which can be a real problem. So they're some of the symptoms that we're talking about. Probably not all of them, but I think we covered a fair few of them. How common is it? This is an old study, more than 20 years old, but it's Sydney. No one's done it quite like this since, but I think Marie will present some figures that show how common it is. But this was in one study, and this, as I said, 22 years ago. And you can see it was aggression, anxiety and agitation, because these are the things that worry the staff and the families. Delusions, activity disturbance, so being agitated or wandering, then mood disturbance, diurnal disturbances, hallucinations and resistiveness to care. It's interesting, apathy is quite common, but you don't get people complaining about apathy nearly as much because people just sit. Different types of dementia have different symptoms. So we know depression is common in vascular dementia. Hallucinations, really common. They're one of the features of dementia with Lewy bodies, vivid visual hallucinations. The compulsive behaviours in frontotemporal lobar degeneration, and delusions in Alzheimer's disease, that absolute certainty that her husband is having an affair when he goes out to play golf, or that someone's looking in through the window, or the carers have stolen all my money, those sorts of things. We know that pathology in different parts of the brain can also predict symptoms. So in the frontal lobe, you get the behaviour problems, the disinhibition, depression. In the basal ganglia, delusions, temporal lobe, delusions and hallucinations. There's quite a few, you can localise it. Not that it really helps, but I guess it's interesting to know. And we also know, and this is more important, changes in neurotransmitter levels can predict symptoms. So this is how we often treat these particular symptoms. So if you've got decreased serotonin, which is a very important neurotransmitter, aggression, agitation, anxiety, depression. So how do we treat these? We use a serotonin, an SSRI, a specific serotonin reuptake inhibitor, so something that increases the amount of serotonin in the brain. If there's decreased noradrenaline, you see depression, and for those we would use the combined drugs that increase both serotonin and noradrenaline, such as venlafaxine is a good example. So it's often worthwhile thinking about, I wonder what's going on underneath. Why do they happen? Multifactorial, millions of causes. Brain pathology is just one part of it. Biological factors, what else is going on? Psychological factors, have they always been unhappy or depressed or a bit paranoid? What's the environment like? And what are the social factors? What's the family situation like? And this is something from a paper by Colin Cunningham from DSA, Dementia Support Australia, and no doubt Marie will talk to this. It's really interesting when you look at what is contributing to BPSD in the residents, the patients that they are seeing. Just look at this: pain, 47%. I suspect it's higher in some situations. Just undetected, untreated pain. The carer approach is huge. I watch how carers approach their people they look after. And I love the concept of therapeutic fibbing. That is where you actually enter the reality of the person. And if they say it's Saturday, when it's Wednesday, you don't contradict them and upset them. You just say, well, if it's Saturday, let's go for a walk or do this or do that. People have trouble, with the fact that you're going along with something that perhaps isn't right. But the concept of therapeutic fibbing, if you want to Google it, it's certainly significant. And I have to say, we all use it to some degree, day to day. And then the other areas that DB Mass brought up, or DSA, the overall understimulation, and a whole lot of other areas. So there's a huge amount you can do before you resort to medication. Now, I'm going to give you 6 rules for management of BPSD, and these come from a colleague of mine, an older colleague, Brian Draper, who is an aged care psychiatrist, now semi-retired, but he's quite happy for me to use these because I think these 6 rules of management are really, really useful. Number 1, any new behaviour that develops quickly, say over hours to days, is an acute medical problem, due to an acute medical problem, unless proven otherwise. And delirium would be the commonest by a long way, and that can be hypoxia, infection, drugs, all sorts of things. So rule 1. Rule 2, most people get grumpy if they're in pain or discomfort. And remember what I said earlier about the number of people who actually have underlying pain. But if you've got the pain, but constipation, incontinence, immobility, pressure injuries, you can't see or hear, and no one's put your hearing aids in or given you your spectacles. Hunger, physical restraint, huge problem when it's used, which it fortunately isn't nearly as much now, and being too cold or too hot. So remember that. You're grumpy if you're in pain, because we all get grumpy. The third rule is behaviour can reflect how the brain's working. So how the cognitive impairments are affecting behaviour. So if you've got memory impairment, you're going to ask the same question again and again. The person you're asking it of is going to get frustrated. You're going to sense that. You're going to get upset, and it kind of escalates. Frontal lobe damage, either apathy. I don't get, as I said, that many people complaining of that, but the disinhibition can be really, really difficult. Language deficits, so people don't understand what you're trying to say to them. So obviously you've got to use simple language and maybe body language. And certainly we know the more severe the cognitive impairment, the more the increased chance and severity of the symptoms of BPSD. Rule number 4, that the person is trying to tell you something. The person's behaviour is a way of communication. So what are they trying to say to you when they're behaving in a certain way? Because they may not be able to say it in language we understand. So aggression or resistive behaviour during, say, personal care may be due to misinterpretation of the intentions of the carer, or embarrassment or fear. Rule 5, people tend to react to things they don't like about their environment. Now, I think we're all like that. So is it comfortable and pleasant and familiar? Is it private? Does it feel safe? Or is it the opposite? Is it loud? Is it noisy? Is it open? Are you scared? Can the staff communicate, or are they too stressed or too busy, or simply not there? Are there activities that are meaningful and purposeful? And I think that's huge. As my mum progressed through the 6 years of her residential care, the activities that the staff in HammondCare, and she was in 3 different facilities, the activities that they had her doing gradually changed as her abilities changed or decreased. But, you know, helping with vegetables, preparing vegetables, making scones, a whole lot of things at the start, hanging out the washing. And towards the end of her life, she would be folding washing, or just doing things that were meaningful and purposeful and meant something to her. And that's the same for all of us. We don't want to just sit there staring into space. Can family and friends come? How do we involve them? And are there problems with other residents interacting? That can be a real issue. And then finally, I'm always asked, does the person have a past history of a mental illness, like a depression? Or did they have a touch of anxiety or psychosis? What's happened in the past? So they're the 6 rules. And then you've got to think, okay, what are we doing? What's the symptom of what's the behaviour of concern? What is it we want to do something about? You know, why, when, where, what makes it better, what makes it worse, how long, and how are you going to measure it? Really important to be able to do that. Does the behaviour actually require intervention? Is it distressing to the person, or to family, or to staff? And we often used to joke when we were giving an antipsychotic that we should really be giving it to the staff, because they were upset. The behaviour itself wasn't upsetting the person, and it wasn't dangerous. I think of some of my patients, and one lady the other day whom I saw, and she sees children in the corner of the room, but she knows how to deal with them, and they leave when she asks them to. And her family, her daughters, were getting really worried about this. And I said, look, it's not distressing to her. Why would we give her medication? She understands that they're not there, and her husband deals with them really well. Is it dangerous? One of my classic examples was a Vietnam War veteran who kept seeing the Viet Cong coming through his kitchen window and would literally flatten his wife on the kitchen floor, you know, pull her to the ground and lie on top of it so she wouldn't be shot. Now, clearly that particular hallucination is dangerous. So you've got to think about, you know, how do you treat it, and, you know, who's at risk? Look, and I've mentioned it before, look and correct the physical factors. A person is grumpy if they're uncomfortable. Look at why. Give them their hearing aids back. Give them their walking, give them their spectacles. It's really important. If they're bored, see what we can do there, and certainly correct the environmental factors. And we know that the small home model, the cottage model of care, is the best care for people with dementia, because it plays to their strengths, if you like, and doesn't cause a lot of the problems that you see in the more institutional care. And there's really good evidence for that. So how do we manage it? So for non-pharmacological, which we always do first, look at the environment. And this is what DB Mass do beautifully. They go and they look at what they can do about the environment. Think about what's important for you, and then make sure your patients have this. You know, good daylighting, maybe a night light, that the person knows it's their home, that it's safe and secure, and that there is adequate access to outside areas. Being able to go outside without having to call a staff member to unlock the door is so important to people with dementia, and it really makes a difference. Allow people to walk freely, regular interaction, so that you don't get the isolation or loneliness, and using regular reassurance. What is there evidence for? And these, I'm sorry, it's a bit of a busy slide, but we know there is good evidence, strong evidence, research evidence for family carer education. Look after teach the carer how to manage. People will manage a lot better and stay longer at home. We know occupational therapy involvement is really important, and the COPE program, care of people in their environment, that is run by OTs with some nursing input, is really, really effective. And training the carers, the professional carers, so they know what they're doing. You'd think that would be obvious, but it's just so important. And then there's a bit less evidence, but it's still pretty good. And I use all these interventions: physical exercise, any sort of physical exercise, music therapy, hand massage and gentle touch, the so-called simulated presence therapy, where you record a video from the family and they play it on their iPad again and again. This was really effective with my mum. The meaningful, purposeful activity, I've mentioned it already, the things that people can do and should be doing. Animal-assisted therapy, dog therapy. I love dogs, and I think it's lovely to see the effect they have on older people, particularly people with dementia. And we know that improves physical activity. And then finally, aromatherapy. And there was a cluster randomized trial that showed this, particularly lavender and lemon balm. Reduced agitation. Now, it wasn't put in a burner. It was actually put on people's skin, and it was done in a randomised way. So people in one residential care facility got the oil without the lavender or the lemon balm. The others got the lemon balm, and it definitely reduced agitation. So some easy ways. So just some examples. This 82-year-old man with sort of moderately severe dementia, he'd been in the facility for 3 years, didn't have much language, didn't really recognise family, and the staff knew him well. He'd been there a while, and he'd occasionally call out, "Help me," and that would mean he was thirsty or uncomfortable, and the staff were able to manage that. But he began calling out regularly, like every few minutes, and the staff thought he was in pain, so they gave him extra analgesia. That went on and on. He then developed diarrhea. He wasn't eating or drinking much, and he just didn't respond to his family or to staff. The GP reviewed him. You look always first for the evidence of a UTI. That wasn't there. But there was some bloating and tenderness, and there had been some gastro around, so they thought maybe it was that with the diarrhea. But then 2 days later, the GP did a rectal examination, and this guy was really constipated. He had significant fecal impaction, and of course you get diarrhea around it, so you don't realise that's what's happening. And because he had been on codeine-containing analgesics, so he required a fleet enema and appearance. And he did after it took about 2 days, I think, he did improve. And the calling out reduced to his normal once or twice a day. Very simple, but you have to think about it. This lady who was quite withdrawn, she'd been in care for at least a year with moderate dementia, and was always quiet and down, and antidepressants didn't help. When the facility started a music therapy program, all the residents got an iPad. She didn't want it. She refused the earphones, but the staff persisted. And eventually she began to listen. And over a few days of the music, 2 hours morning and afternoon, she became more interactive and smiling, and then began to hum along. Now she's on her second iPod, and the improvement has continued, but you have to persist. Third case of a lady, moderately severe dementia. She had a hip fracture, and the surgery didn't work, and she was really stuck in the chair. She was always calling out for her son, But when he came, or anyone else came, she didn't know what to say. And she lived on a sheep property most of her life, literally till about a year before moving into care. And when we talked about bringing in a staff member's Kelpie to visit her, because she'd had Kelpies, and her eyes lit up and she smiled for the first time in weeks. And that dog spent several hours a day in her room, and her calling out reduced significantly, basically to nothing. That was the use of of animal therapy. And just a funny addendum to that, when the staff member was away for 4 weeks and the Kelpie didn't come in, I was very clever and I thought I'll get her one. So I bought her a stuffed Kelpie and took it into her, and she looked at it and she started stroking it and put it on her lap. Then after about 2 minutes, she looked at it again, she picked it up and she threw it at the wall and she said, "Bloody thing's dead." And my granddaughter got a very nice stuffed Kelpie out of that. But it was a bit of a lesson that, it's the real thing that matters. But when the Kelpie came back, this lady really lit up again. It was lovely to see. Okay, so let's look at pharmacological management, so the drugs. And we say don't use drugs till you've tried everything else. And remember that the drugs are not that efficacious. Quite often, the effect is really modest, and sometimes the placebo effect isn't nearly as great. And I think that's what we forget. We think, oh, it's a drug, it's approved, it'll work. Quite often the answer is no, it doesn't, or it doesn't do what you want it to do. And again, go back and think, what is it you're targeting? Because we'll look at which symptoms respond to which drugs. And again, and I'll say it again and again, always go back and look at any underlying causes that you can treat, whether it is a bladder infection or pain or constipation, or are they, thirsty. And always make sure when you talk when you see the patient, you're involving family and staff, because they know the patient a lot better than you probably do. So what do we use? For agitation and anxiety, the SSRIs have the most evidence. And citalopram is the one I would always use. So we just remember serotonin decrease causes these symptoms. So you're trying to increase it. We also know that analgesics have been shown to reduce agitation in a very nice trial published about 14 years ago. And so you can, you're looking at untreated, undiagnosed pain. Antipsychotics can be effective, only if you haven't tried the others. And benzos, the benzodiazepines, I would always use lorazepam, although I try not to use it too much. And that can settle anxiety quite well, but you become tolerant to it very quickly. So you've got to be careful. And don't, for goodness sake, use a long-acting one like diazepam, Valium, because it lasts forever. If someone's got depression, remember again, the serotonin, decreased serotonin. So you use those again, looking at, say, citalopram, or one of the combined ones that increases both serotonin and noradrenaline. We know from the studies that there's no evidence for the use of sertraline, Zoloft, or mirtazapine, but there is evidence for some of the others. So when people say, oh, there's no evidence for antidepressants, there is no evidence for some antidepressants. Aggression. Antipsychotics, if it's really, really bad, risperidone's the only one listed on the PBS. And you try not to use too much, start low, and always look for EPS, extrapyramidal symptoms, the Parkinsonian. You must look at that. And we always say, review after a week, see how it's going, and then always look at sort of reviewing and stopping in 3 to 4 months. We know olanzapine can be used, but using it off-label. It's not on the PBS. For psychotic symptoms, if there is distress to the patient or others, then you're looking at the antipsychotics. For sleep-wake cycle reversal, people get up at 3 a.m. and want to go to work. We look at, there's a few ways, but melatonin can induce sleep. It's not a sedative, it just induces sleep, and you might want to use a sleeping tablet. Apathy, which can be quite difficult to treat. Sometimes the cholinesterase inhibitors, which are what we use to treat the symptoms of early to moderate dementia, that can improve it. And if someone's apathetic because they're depressed, then clearly antidepressants can help. The things we do have trouble with: inappropriate vocalizations, that's the shouting or the calling out, the help me, help me, help me, the restlessness and wandering, and sexually inappropriate behaviours. They can be a bit harder. There are ways to deal with it, but that's very much, I say, called DSA for some of those. So just remember that you do need to get consent for treatment, because in New South Wales, psychotropic medication's major medical treatment. If it's absolutely urgent, you can treat them under the Urgent Medical Treatment Act, but then you need to get consent. If you are using them as chemical restraint, and I hope no one ever does that, you actually have to get permission, consent from the Restrictive Practices Substitute Decision Maker. And in New South Wales, they have to be appointed by the Guardianship Tribunal. You can't be a guard, you can't just, as a guardian, consent to that. But remember this: chemical restraint should never be confused with the appropriate use of psychotropic medications to manage the symptoms of mental illness or dementia, as I've described. So just finally, some quick examples. This lady, she was 68. She'd had a diagnosis of Alzheimer's disease, I think, for about a year. She was convinced her husband was having an affair. This is the lady that when he went out to golf, she was sure he was going off to see his lady friend. She would stand at the door with her arms out and not let him out. We decided, after a lot of other ways of trying to deal with it, to try her with some risperidone, 0.5 milligrams twice daily. After 2 weeks, the husband reported that he's got his wife back. He was really reluctant to consider reducing the dose. He called it his chill pill, but she was doing okay. She's now down to none for 6 months. We halved it, but he has the box in the cupboard just in case. But again, a delusion responded to an antipsychotic. This lady with vascular dementia, she moved into residential care after her husband had died, and she constantly was asking staff where he was, and then became very distressed when they told her that he was dead. And she would say, "Why didn't anyone tell me?" And then they'd show them the photos of her at the funeral, and he said, "Oh," and she would say, "It's all made up." Distraction, exercise, everything else failed. But on citalopram, gradually increased to 20 milligrams a day, which is a standard dose, she gradually improved. She stayed on it. She's now been on it for 12 months at least, because when we tried to withdraw it, she just started getting upset about her husband again. But it really did take the edge off. This lady, during the bushfires, this lady had moderate dementia. She was living at home, could still do things around the house. She became convinced during the bushfires that she was the cause, and they'd been sent to punish her and everyone else. She tried to stab herself with scissors. We had to bring her into hospital, both risperidone, antipsychotic for the delusions, and venlafaxine as an antidepressant. And she had actually three weeks in hospital, markedly improved after a period of time. We were able to cease her risperidone, but she remains on the venlafaxine. So they're just some examples, lots more. And I just want to finish with, if you need help with management, don't forget the Geri to GP service in Ryde Hunters Hill. You've got the numbers up here. It's Linda Zoo. On the Lower North Shore, it's Prav. And in Hornsby, it's now Radesh. And the phone numbers are there. There are also geriatric outreach services, and we're still working out whether we get a single number. And there's Dementia Support Australia. And with that, I'm going to hand over to Marie, who will now talk about Dementia Support Australia. So I think you share your screen and go for it, Marie.
Fabulous. I will do that as we talk. Let's see how we go. So let me just bring it up to full screen for everybody. And thanks, Sue, for everything you've just talked about there, because I think it sits nicely with what I'm going to talk about. Just change that over to presenter view. There we go. That should be working for everyone now. So really what I want to talk about are some of the questions that I've heard come up when I've been talking with HEMA and other people across the PHN. So I wanted to start with some perhaps confusion that's out there around some similarly named programs. So Sue's talked about Dementia Support Australia, which is the program that I lead here, which is a national program. But of course, our name is very similar to Dementia Australia. What I like to say to people is, with all of our services, even though we are two separate organisations that do quite different things, there is no wrong door. So if you do go through the door to Dementia Australia, but you're requiring behaviour support, they will send you back to our service. And conversely, if you come to us, but you're looking for something that is better provided by Dementia Australia, so something much more around advocacy and information, carer support, those sorts of things, we'll send you to Dementia Australia. But what we do at DSA, we're an Australian government funded program. So I've been lucky to be involved in the behaviour support programs funded by the Australian government for coming on 20 years now. So the programs will be very familiar to you, and I'll take you through the names of each of those. But we operate them under the banner of Dementia Support Australia. And again, that's about saying it doesn't really matter which program you need. If you come through the door of Dementia Support Australia, we'll get you the right support. We're a free program, so that's a really important fact to talk about. So there's absolutely no cost to access our services in any way, shape or form. We also offer brokerage. And so some of the things that Sue was talking about, the non-pharma strategies, such as animal-assisted therapy, or we use a lot of simulated pet therapy. So we do use the stuffed collie dogs and the stuffed cats with great impact as well. So we're able to support funding for those sorts of things, but there's no cost for our service. Our eligibility criteria is really simple. Have dementia or diagnosis of dementia or suspected dementia, because we know that in aged care, in residential care, sometimes people just don't get a diagnosis, but it's really clearly obvious that they have a dementia and the behaviour is related to the dementia. So have a diagnosis or a suspected diagnosis of dementia, have a behaviour that's impacting the care of the person living with dementia and the care network around them. So, you know, Sue talked about sometimes the behaviour isn't an issue for the person with dementia. We might be actually supporting the care staff or the family members to better understand how they might support the person with dementia. And of course, the third criteria is around consent. So we need consent from parties involved. Great to get consent from the person living with dementia or their substitute decision maker. We deliver services anywhere. So it doesn't matter whether the person with dementia is living at home, is in a community or a day respite or an overnight respite setting, in residential aged care. And we support within acute care primarily around the transition out. So someone who's been stuck in a hospital setting for a long period of time, who's really finding it difficult, the family and the social work team are finding it difficult for a care home to support placement, we can work with that placement opportunity. We're on the ground and we provide both what I call proactive and reactive support. So we're not a crisis service, and you saw that in Hoda's Dementia Pathway, but we can get out there within 48 hours to 1 week on the ground. We have a range of resources and guides, and we also operate 24 hours a day, 7 days a week, 365 days a year, regardless of public holidays. So you will always be connected to a behaviour consultant, whether you ring at 11 p.m. on a Saturday night or 2 a.m. on a Thursday morning, you'll always be connected. So some of these program names will be quite familiar to you all if you've been around for a long time. And I guess, again, that overarching banner of Dementia Support Australia is probably the most important thing to remember, because if you go through that doorway of the 1-800 number that Sue had up, and we'll show that again at the end, we'll make sure that you get the support that you need. But we do have a range of different programs that are funded through DSA. I'll start with DBMAS, which is the second column there, and is the one that I think is talked about in the pathway, probably also because it's the one that's been around for the longest time, since around 2006. So that service is primarily designed to support people where behaviours are less severe. So we really have a focus on much more proactive support. In that particular program, we aim to be on the ground within 1 week of receiving and triaging your referral. So that's on the ground regardless of where the person with dementia is living. So at home, in residential care, anywhere. So we're able to provide that support. Of course, what you'll get when we're triaging and taking that referral is we'll give you some interventions over the phone of things you can start to think about and consider. So, have you looked at environment? Have you considered a UTI, as Sue was saying? The severe behaviour response team was designed to support those more severe behaviours. Now, it is only available in residential care settings, but what I like to tell people is if you're living at home and you're having very severe, there's an impact of very severe behaviours, you'll still get the same level of support just provided through DBMAS. But SBRT can be on the ground in residential aged care anywhere in Australia within 48 hours. So that's a really important thing to remember. And we tend to be engaged with you for a little bit longer because the behaviours have a lot more risk and a lot more impact. So when we're thinking about what defines the two services, it's the risk both to the person with dementia and the care network around them. So really the severity and the frequency and the intensity of what's going on. And so we'll ask a lot of questions to understand what's happening. The final part of the programs that we support and a really important part of the suite of services that is offered is the newly funded specialist dementia care programs. So these specially designed cottages and funded units are for people that mainstream residential care can't support. So there are people whose behaviours are no longer able to be supported in mainstream, and quite often they end up in acute care settings for a period of time. The specialist dementia care programs are 8-bedded cottage style units, so quite small. They're transitional care, and what they aim to do is support the modification or the reduction of the impact of those behaviours so the person can actually re-enter mainstream residential care. The downside here in New South Wales right now is we only have one of those units, and it is located at Cardiff. However, the good news is it's a boundaryless service, so it doesn't matter where you come from. There's no PHN boundaries here. You can have anyone can apply for assessment to the Cardiff unit. And I think in the next few weeks, we'll have some announcements about some new units here in New South Wales as well. So that'll be great news to support people. So our role is to assess for eligibility, not for placement. Placement sits with the residential aged care provider who operates the SDCP. For us, the new program in our suite of services here, and it aligns to what Sue was saying in terms of the importance of carer education and support. So we're just kicking off the Staying at Home program, and so that's really for people who are relatively newly diagnosed, the primary and secondary carer, and the person living with dementia attending at what's called a residential respite program. So it's a live-in program for 2 nights and 3 days in a respite cottage. We are running some day programs as well, given the current COVID climate that people might not want to stay overnight, but our first few programs are actually booked out. What happens at these programs is people with dementia get their first experience of what respite might feel like. So we're demystifying respite to people living with dementia, and we're providing carers with some education around looking after themselves while they're looking after the person living with dementia. So it's a really important new program as part of the suite of services in actually being proactive and hopefully avoiding some of the things that would get typically referred into us through DBMAS. What we do is really has been built on feedback that's come from the industry over the last 6 to 8 years through previous iterations of the program. And so for us, we're a national program, so a boundaryless program anywhere in Australia. Of course, you're very interested in what's happening in your area, so we'll talk about some of those stats. But again, timely boots on the ground. So for us, getting out on the ground is important. That doesn't mean that sometimes you won't be offered a telehealth appointment. What we're trying to do with the influx of referrals that we have at the moment, particularly with the current, obviously, workforce issues in aged care, is look at things that we can support over the phone. So we're really getting out to those high-risk referrals as fast as possible. We have a range of medical specialists on our team. So Professor Steve McFarlane and Dr. Duncan McKellar are key medical specialists that support medication reviews for our severe behaviour response team, clients that come into the service. But we also have a range of other medical specialists that support the reviews of our report and can provide additional support into the sector as well. For example, we've been providing some support into Bega, which currently hasn't had access to a medical specialist for quite some time. We work with a lot of industry partners such as Winteringham in Victoria, who are experts in homelessness and drug and alcohol issues. So where they exist, we're able to support with the additional help of their skills and knowledge. And we also work with the Childhood Dementia Initiative and Batten's Disease and Support Research Australia about the issue of childhood dementia, of which there are quite a few cases in New South Wales. So what we do really aligns well with what Sue was talking about. So we offer a biopsychosocial model of care. On the left-hand side, you can see some of the things that she was talking about. But of course, what's presented to us when people refer into our service are things like aggression and agitation, because they are the things, as Sue said, that really literally hit you in the face. They're the first things that people see. What we want to do is get underneath what that presentation of behaviour is and really identify what's contributing to that behaviour. As Sue mentioned, pain is undiagnosed, undertreated. Pain is a significant cause of behaviour still for people living with dementia. And I think it's really an area for focus from us all. And it's something that our consultants talk about a lot when they respond to referrals. But again, there's a whole range of other things behind that. For us, it's really important to understand the person. And so whilst that may seem quite time consuming to aged care providers and community care providers to understand the life story of the person, without that story, we can't provide really tailored interventions and recommendations, because a lot of the times what we see is a natural response to what's happening for the person. So for example, someone who might have had a significant domestic violence situation, who's then in a care home surrounded by large younger men with cognitive impairment, may start to relive some of that through PTSD. So it's really important for us to get underneath the story of the person and understand what's going on. And again, for us, it's really about de-prescribing. A lot of what we do is actually pulling back and saying, let's have a look at what the non-pharma interventions can actually achieve here. What's really important is we need the investment from the care providers that are working with us. We're not the experts. You're the people that are supporting the people living with dementia 24 hours a day, whether at home or as a care provider or as the GP supporting the family. So we really want to work in partnership to understand what's going on. In talking with HEMA and the team around the Dementia Support Australia service, there was a little bit of concern that perhaps there hadn't been access to the program from services in the Northern Sydney PHN. So I wanted to give you some comparative data as well as just some straight data about what we've done over the last 3 years and 6 months. So up the top is Western Sydney PHN, which is kind of a comparative size in terms of your PHN. So you can certainly see that we are getting considerable referrals from your area. And the source of those referrals are primarily, and not surprisingly, from residential aged care. Informal carers and community referrals make up about 9% of what we do in the Northern Sydney PHN. That tends to change depending upon what's happening. So, during times of COVID, when people were coming out of care, our informal care and community referrals definitely increased, but not surprising that residential aged care is the biggest user of the services of DBMAS. Of course, SBRT is only available in residential aged care. Looking at why people refer into our service from within Northern Sydney. So again, not surprisingly for both DBMAS and SBRT, it's the same reasons, just flipped around. For SBRT, where it's that much more severe presentation and higher risk of behaviour, it's that physical aggression. So the things that you see that are really confronting. And typically the clients in SBRT tend to be male and slightly younger in comparison to the clients in DBMAS, who are usually female and are slightly older. Verbal aggression figures quite high in the reasons for referral there as well. We use the neuropsychiatric inventory to really understand the outcomes of the work that we do in partnership with you. So I think it's really important. You know, we can give you data such as how many people we've seen every 6 months or 3 years, but what's more important is to understand the impact of the work that we're doing. So is it actually making a difference to you and the people that you're supporting? So you can see from this NPI data over 3 years and 6 months, we have significant reductions across all the domains. Interestingly, in SBRT, those reductions are higher than they are in DBMAS, and that's likely because the behaviours are a higher severity in SBRT. So when the outcome is more successful, there's a much more noticeable reduction in that severity and distress domains. If you wanted to have a look at how we actually evaluated some of those outcomes, this is one of the articles, and I'll share these slides with Hema and Hoda and the team afterwards, so that you've got them. But this talks about how we use the NPI to actually demonstrate the impact over the pharmacological intervention. So a really interesting and good paper to actually give a bit of weight to the things that Sue was talking about in terms of non-pharma interventions. In talking with the team as well before we came on to do this, there was a bit of conversation around confusion, particularly with general practitioners. And I know we've got some GPs and practice managers online. So I'm really hoping that you received these packs in the last couple of months as part of our GP campaign, because I understand they went out to practices in Hornsby and Lane Cove, Mossburn, Northern Sydney, Ryde, Willoughby, just to name a few. And so these packages really contained a lot of information about our service and how you can get in contact with us very quickly, what we can offer general practitioners and practice managers to support the people that are coming into your services. We also run campaigns for residential aged care as well, but this most recent one has gone out to GPs. So I'd be really interested to know if people didn't see these in their practices, because we will follow that up, because it definitely should have been received by all practices. Some of the things that you can access through the Dementia Support Australia website for aged care providers that are online. Obviously, legislation from September 2021 means that you now have to have behaviour support plans as evidence of what you're actually doing when somebody does have a BPSD. And so we have a great toolkit of resources there that really take you through understanding how you can appropriately and adequately document, both for legislative purposes, but actually to improve and enhance the quality of care for the people that you're supporting. And just finally, we've got a new program commencing in 2023. It's kicking off with a pilot in South Australia in the next few weeks. And we've got some small scope for pilot studies here in New South Wales. So this is a deprescribing, I call it a prescribing line, more so than a deprescribing, but it is for GPs to help with answering some of those questions. What we see when our staff are working on the ground in care homes is some of that requirement to actually support GPs with taking another look at what's actually happening, looking at the non-pharma interventions that we've provided, and really looking at what we might do to make a difference. As Sue said, we don't have drug treatments for vocalizations or sexually inappropriate behaviour or intrusiveness for people. So there are lots of other things that we should be doing first, and this line, which Duncan McKellar is going to kick off for us in the next few weeks, we really hope that will support some of those recommendations from the Royal Commission. So just quickly a reminder, we're 24 hours a day, 7 days a week. We go absolutely anywhere. All you need to do is refer into us. So don't just expect us to turn up. You actually do need to refer into us. We've had that confusion lately that people thought we would just turn up, but you actually have to make a referral for us to get to you. But you can do that through our 1-800 number. Live on our website, we have a form you can just download, or there's a live chat as well anywhere in Australia. Thanks.
Thank you, Professor Sue, Kurrle and Marie. Alford, thank you so much for your time. This was incredibly helpful and interesting. We have a couple of minutes now for some questions. So I put it out to our participants. If you do have any questions, please put it in the chat box and we will hope to answer them. We do have a comment here from Linda, and it's probably for you, Marie, just around how to get those packs into the practice. Any ideas?
Definitely. So I'll make sure that my email address is available to the participants afterwards, or you can just email the DSA program. Let me know if you didn't get a pack. We will get you a pack as quickly as possible, but really keen to share that information. So interesting that you didn't get it, and I will follow that up as to why your practice didn't get one.
Wonderful. We'll link you guys in. Any other questions from our participants?
Hodder, I just wonder if I can ask a quick question that I've been asked quite a bit is post-diagnosis, what sort of support mechanisms are there for GPs for their patients soon after diagnosis?
Do you want me to start with that one, Marie? Because as you say, they've got to be referrals and they do have to have a reason. Hema, that's something we're working on. It was a recommendation of the Royal Commission that there be post-diagnostic pathways. The memory clinic at Hornsby is hopefully about to start a one-day-a-weeker where Bronwyn Cook, our cognition nurse, follows patients up. We do it in a very ad hoc way with some patients, but it's terribly hitty-missy. Once upon a time, the aged care assessment team might get involved. Now, of course, they're just assessment. There's not much management. There are, I mean, the support services that you mentioned at the start, the DCAF, the Dementia Australia helpline, there are support groups. All those have kind of gone into hibernation or decreased during COVID, but they are starting to come back up. I think, Marie, you probably need to have a CHSP. You need some funding for some of them, don't you? Unlike DSA, they're not always free. But there is a bit out there. There is some stuff on health pathways, but that list you put up at the start, I thought, Hodder, I think you put it up, or no, it was Hema. Anyway, was that certainly got some good ideas, and getting people to the DCAF, we would use those. But it is really, really difficult. And people often need that little while to adjust to the diagnosis and think about the future. And that's why I tend to get people back after, 4 or 5 months so that we can talk through those other things that they're not going to take in at the very first, the first visit or when you give the diagnosis. Marie, have you got some other suggestions?
Yeah, look, I think when someone's newly diagnosed, as you say, they sometimes need a bit of time to think about things. Dementia Australia is a really good first point of call in terms of information and support. They don't offer case management. None of us are funded for case navigation. Until you get connected to a home care provider, that's sort of a bit of a hit and miss. We have that new program, Staying at Home, which can support people with a relatively new diagnosis. But what I would say is connect people to Dementia Australia as sort of that information advocacy support, and just stay in contact. And so when things change, if behaviours change, you can refer into our service, obviously. And again, if we're not the right service and you refer into us, we'll make sure we get you to the right service.
Wonderful. Thanks. Thank you both. I think that's probably it for tonight. I don't see any other questions coming through. The last thing I will share is our evaluation. So on the screen, you hopefully will see our QR code, which will send you a link to the evaluation. So if you do have any feedback or further questions, please do list that on the evaluation and we will get in touch with you. And again, if you do have any general concerns, questions, or want any other information around our services, please do reach out to the Primary Health Network. Thank you everyone for your time, and a special thank you to our speakers today as well. Thank you.